Hello everyone and welcome to today's webinar, Pathway to Implement Congenital CMV Screening and Future Legislation, One State's Progress. I'm Cassie Soltman of LabRoots and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Diasorin. To learn more, visit www.diasorin.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We'll answer as many questions as we have time for at the end of the presentation. Also, if you experience any technical issues, you can utilize this Q&A box and we will assist you directly. I'd like to now welcome our speaker, Dr. Eileen Raynor, Associate Professor of Head and Neck Surgery and Communication Science and Pediatrics and Division Chief for Pediatric Otolaryngology at Duke University School of Medicine. Dr. Raynor, you may now begin your presentation.
Thank you. Well, thank you so much for that introduction. Today we're talking about a pathway to implement congenital cytomegalovirus screening and future legislation. We'll be talking about my home state, which is North Carolina, but there have been quite a few states that have implemented legislation for CMV, and we'll talk about them as well. So as part of this, we're going to talk about the North Carolina CMV work group, its creation and mission, which I am a part of. We'll review the congenital CMV and kind of discuss that as well, and then talk about some legislative advocacy, some controversies around screening, and where we are in North Carolina specifically. So the CMV work group was established back in 2019 because there was a concern about the lack of awareness in the state of North Carolina, both on the side of patients and on the side of providers. So we started initially with in-person meetings, and then something called COVID happened in 2020. So we ended up transferring initially to teleconference and then ultimately to video conferencing. The work group consists of multiple stakeholders, including audiology, pediatric infectious disease specialists, pediatric otolaryngology, OBGYN, general pediatrics, members of the Department of Health and Human Services, and the Early Hearing and Detection and Intervention Group, Beginnings, which is a parent advocacy group for children in North Carolina who are deaf or hard of hearing, the National Cytomegalovirus Foundation, and parent advocates. And we conducted several webinars and surveys statewide to really increase awareness about congenital CMV. The mission of the work group is to determine collaborative approaches that support prevention and reduction of CMV infection in both women and children, to find timely diagnosis for congenital CMV infections, ensure access to care, and support outreach and education for both providers and for patients. This is the landscape in 2019. So in 2019, you can see the teal colored states have some sort of screening or education law that was enacted. The two orange states have some other law related to CMV enacted. And then the gray states, of which North Carolina is one, have some sort of stakeholder interest in legislation. And there's strong professional and parent support for these projects. Currently, 2024, you can see a lot more states in that teal color where they have some kind of screening law or education law enacted. Most of these states are doing hearing targeted screening, and we'll talk about that a little further on in this webinar. But some are also doing universal CMV screening. You can see a few of the very light colored states like California and Michigan. Those have some laws that have been proposed. And then again, the gray states that have stakeholder interest, but no active legislation. So why does this matter? What's the point of all of this? So CMV is an extremely common virus. It affects 1 in 200 newborns annually, which is around 2,500 children in the United States a year. It's the most common congenital infection both in the US and in the world. And about 20% of these children can develop permanent health problems. In 40% of children who are born with symptoms of cytomegalovirus, they can have sensorineural hearing loss. And in about 8 to 12% of children who have no symptoms at birth, they can also develop sensorineural hearing loss. So here in this graphic, you can see 1 out of 3 pregnant women who become infected with CMV can pass it to their unborn child. 1 child is permanently disabled by CMV every hour, and that disability will vary in severity and presentation. And then 1 in 200 children are born each year. So it's a pretty significant problem. CMV is a virus that is part of the herpes family of viruses. It affects anywhere from 60 to 90% of adults. Most adults who get CMV have very minimal symptoms like upper respiratory tract infections or may be completely asymptomatic. Again, it is the most common congenital infection and the leading cause of non-genetic hearing loss in the United States. And every pregnant woman is at risk of transmitting CMV to their newborn, but less than 10% of pregnant women, or all women actually, know about CMV. It's serious and preventable, and that's one of the most important things, is educating pregnant women on how to prevent getting CMV and transmitting it. This graphic shows the virus makeup. So you can see it has an outer coat and then a glycoprotein structure. Inside the middle is the capsid, and then the genome is housed within that. And this is where virus vaccine technology is being targeted to try to get some vaccines for CMV. Currently, we don't have any vaccines available. So the terminology is actually recently changed. Symptomatic cytomegalovirus is identified at birth and affects about 10 to 15% of children who have congenital CMV. And these symptoms can include things like petechiae, thrombocytopenia, microcephaly, hepatosplenomegaly, jaundice, and chorioretinitis. Prior to 2021, failed newborn hearing screens was not necessarily considered as a symptomatic finding of congenital CMV. But as of 2021, that definition changed. And now if somebody failed their newborn hearing screen and is positive for CCMV, they are considered symptomatic. For asymptomatic babies, which affects the majority of them, 85 to 90%, they have no distinguishing birth features. So you wouldn't necessarily know that they have CCMV unless they're tested for. However, these children can still develop late onset sequelae, such as sensorineural hearing loss, vision loss, neurologic problems, developmental delay, including speech delay, and vestibular balance dysfunction. Symptomatic CMV will demonstrate findings on MRI scans, such as periventricular white matter changes, and you can see those by the yellow arrows on this MRI scan. Again, hearing loss, which can change over time, and we'll talk about that more in a minute. Vision loss, mental disability. They may see some intracranial calcifications on imaging. They can have a lack of coordination or cerebral palsy. They may have feeding issues or failure to thrive. They frequently will have sleeping problems, behavior problems. They may have seizures, and they may even have mortality. Again, it is the most common cause of congenital infections worldwide, affecting anywhere from 0.2 to 2.2% of all births. People in low and middle income countries have a 3 times higher risk of passing it on to their babies compared to higher income countries. And this can be the result of both a primary or de novo infection or a recurrent or reactivation. Primary infections have a higher risk of transmission to the fetus, up to 40%, and recurrent infections are much lower risk, about 1%. And again, this can be due to reactivation of a latent virus that the mother has already, or reinfection with a different strain. Young mothers, single marital status, non-white race, and lower socioeconomic factors have been shown to increase the risk factors of mothers acquiring CMV and passing it on to their newborns. The influence of social determinants of health in CCMV is also fairly well established, and that Children who come from lower socioeconomic statuses and are non-white have a much higher rate of obtaining CCMV. Um, Black people have a 2 times risk of non-Hispanic white. And this is thought to be due to having more children of younger age in the home, closer living conditions, children who are in daycare, younger maternal age, which increases the risk of getting a primary infection. Um, and there is a 24% or 24 times increased risk if the mother is seronegative at the first pregnancy and then at the second pregnancy gets CCMV. So there's a much higher chance of that. There was, interestingly, a French study that showed an increased risk in higher maternal socioeconomic status and birth in the high income countries, but there was not a great explanation as to why these findings were seen. This graphic just shows the seroprevalence of CCMV in children and women of childbearing age. So the dotted line at the top is the non-Hispanic Black, and that you can see the incidence at age 10 to 14 is around 40%, increasing to 90% by the time they reach 40 years of age. The solid line is Mexican American, and their risk is about 60% at age 10 to 14 and increasing to about 80% by the time they hit 40. And then the dashed line at the bottom is non-Hispanic white, and you can see that that risk is about 35 to 40% in the young age and up to about 50%. So here you can really see in those childbearing age ranges, everybody has an increased risk over time, but the rates are different. So in terms of these risk factors for CMV infection, primary versus reinfection, on the left-hand columns, you can see primary CMV infection, around 40% of women are susceptible to that. 1 to 4% will experience a primary infection. 40% of those fetuses can become infected, but of those, only 10% may be symptomatic at birth. However, up to 25% can develop sequelae related to this infection by the age of 2. For mothers who have a non-primary infection, about 60% of these are susceptible to a recurrent or new CMV strain. However, only about 0.5 to 2% of these fetuses are infected because the mother has some immunity against CMV. Even if it is a new strain, there's going to be some immunity there that will decrease the likelihood of maternal fetal transmission. Of these babies, less than 1% are symptomatic at birth. But the interesting thing here is up to 8% can develop sequelae by age of 2. So just because there's a small percent that are symptomatic at birth does not leave them out of the woods. And again, we sort of talked about this before, but the potential outcomes are hearing loss, which is usually sensory neural, so it is permanent, and it can change over time. And then these other things such as vision loss, sleeping problems, delayed motor milestones, vestibular problems. So 1 out of 5 children who are born with congenital CMV will develop a permanent health problem with as much as 400 infant deaths annually. So it is a pretty significant mortality rate as well. There's also a big economic impact. So there was a study that was done in 2018 using a large database from the Children's Inpatient Registry over the course of 12 years. And children who had CMV positive tended to be in the hospital anywhere from 15 to 27 days. The costs associated with CCMV ranged from $45,000 to $90,000, and most of these babies were preterm. For children who were CCMV negative, their inpatient stays tended to be 2 days. The costs were anywhere from $2,000 to $3,000, and then less than half of these babies were preterm. Over their lifetime, the average healthcare costs were 2 times greater for those with CCMV, even if they were asymptomatic appearing at birth, and that is due to these later developed sequelae. One of the challenges with CCMV is that the diagnosis is time sensitive. These children have to be identified early because if they have acquired CMV postnatally or after birth, they do not have the same sequelae as if they had gotten it as a fetus. So currently, viral culture or PCR of both urine or saliva needs to be done within the first 3 weeks of life to determine if they actually have CCMV. After 3 weeks, the diagnosis is harder to confirm again because it can be an acquired infection, in which case they would not have any long-term sequelae. Once the culture or PCR is done, you would do a confirmatory culture to rule out a false positive. Blood tests after 3 weeks tend to not be very helpful unless they're negative. You can have false positives from breast milk, or you can have an acquired CMV after birth from other children. Historically, the dried blood spots, which are obtained at birth, have been used to try to determine if a baby had CCMV. And in the past, those really had very poor sensitivity and specificity. Recently, there's been some new DNA extraction methods that showed improvement up to 78% sensitivity and a 100% positive predictive value, meaning if the dried blood spot was positive, you could be pretty sure that the baby had congenital CMV. However, if they were negative, there's still a potential that it is a false negative. One of the issues with the Guthrie cards, or the dry blood spots, is that many states don't keep these cards very long, and it's a huge range across the country as to how long these cards are kept, anywhere from 6 months to 27 years. The average tends to be around 3 to 5 years. So again, it's really difficult to confirm CCMV infection as the etiology of hearing loss after that newborn period due to the likelihood of having an acquired infection postnatally. So as part of our CMV work group, we did a survey across birthing centers across North Carolina to try to find out, first of all, how is CMV tested for at their center and whether they even knew about testing. So here you can see that the majority did urine CMV PCR, and then the next testing was salivary PCR. And then you can see kind of a peak over here on the right at about 32% where they did not know or not sure. So there were definitely some centers that really didn't know much about it or were not testing for it. And then you can see a smattering of other ways that they were tested, ranging from cultures to using the dry blood spot testing. So congenital CMV, symptomatic congenital CMV, can be managed medically, and there's a couple of different antivirals that are frequently used. Ganciclovir is given IV, so those are for children with pretty significant symptoms. They may be kept in the hospital longer to be on IV ganciclovir. Children who have mild symptoms and or children who just failed their newborn hearing screen and follow-up hearing screens may be treated with valganciclovir, which is given orally. There are some studies that have shown potentially prevention of progression of hearing loss or development of hearing loss, but those studies are somewhat inconclusive. So it is difficult to say how much these antivirals actually halt the progression or change the course of whether a baby's going to get hearing loss as a result of this. It can improve developmental outcomes overall, and that is the reason that symptomatic babies are treated for this. There have been a couple of studies done to look at children who just failed newborn hearing screen and otherwise are considered asymptomatic by the older terminology. One of the things that needs to be done is monitoring for toxicity. These children can get aplastic anemia or other kinds of adverse events from ganciclovir or valganciclovir. And then the length of how long they need to be treated for is fairly unclear. So some of the recommendations are starting it within 3 months of age and going for 6 weeks, but then a lot of studies are actually going about 6 months. So there's still a lot of work to be done to determine optimal treatment and optimal length of time for treatment. One of the things that's really important, though, is that both asymptomatic and symptomatic babies should have their hearing and vision checked regularly. So that is one of the important things to educate parents about. So this graphic just shows where the hearing loss occurs. So you can see the speaker going to the external ear that activates the tympanic membrane and moves the ossicles. And then you can see the cochlea in yellow and then the hearing nerve with the red arrow exiting toward the brain. So the area of injury is thought to be within the cochlea, and the cochlea has specialized hair cells that transfer signals from the vibratory movement of the fluids in the cochlea into electrical signals that go to the brain to tell you you are hearing. There's a lot of debate about what the actual insult is, whether it's due to immune complexes, whether it's a direct effect on the hair cells themselves, or if there's some issue in terms of the blood flow to the cochlea. This graphic demonstrates the incidence of CMV both at birth and at 4 years compared to other causes of hearing loss. So you can see in the darker orange area there on the left-hand side, CMV accounts for about 21% of hearing loss at birth, and about half of those are not apparent infections, and about half of those were apparent. And then you can see some of the other genetic causes, whether they're syndromic or not, in gray, and connexin 26 and 30 mutations in that brown color. As we get to 4 years, you can see CMV now accounts for 25% of hearing loss, with clinically apparent infection accounting for 7%, clinically inapparent infection 8%, and late onset 10%. And then these other causes of hearing loss related to genetic problems and enlarged vestibular aqueducts. So there was a large study that was a multi-center study called the CHIME study. And that was, they screened 100,000 newborns. They did universal CMV screening. And the goal of it was to determine both the validity and the clinical utility of universal screening for CMV. In addition, they wanted to determine any long-term audiologic outcomes in these children. So they followed these children closely, and they did sequential audiograms up to the age of 4. What they found is out of the 100,000 newborns, 391 tested positive for CMV, and the overall incidence in hearing loss was about 12%. In 41% of those that were symptomatic, they had sensorineural hearing loss, and in 8% of asymptomatic children, they also were found to have sensorineural hearing loss. There was a large percentage of these children that had late onset, so they passed their newborn hearing screen, but then ended up developing hearing loss later on. The burden of hearing loss in congenital CMV is estimated to be about 7% in those children who are positive and that did not pass a newborn hearing screen, versus less than 1% of CMV negative children. And there's been, this study really renewed interest in both targeted and universal screening for CCMV. So, in sort of to recap that piece of it, anywhere from 22 to 65% of children who were born symptomatic for CCMV will have sensorineural hearing loss. And anywhere from 6 to 23% of children who are asymptomatic will also have sensorineural hearing loss from this infection. There's a variability in the severity, and there's a variability in how it presents. So some of the characteristics of hearing loss in CCMV can be that it can have delayed onset. So usually this will occur before the age of 6, most frequently anywhere from age 2 to 4, but there have been studies that showed later onset of sensorineural hearing loss as late into teenage years. So it's more likely to occur before age 6, but it can occur later than that. It can also be progressive. So about half of these kids who have sensorineural hearing loss will get worse over time. And it's very similar rate of progression for both symptomatic and asymptomatic babies at birth. However, those babies who are symptomatic at birth will have a higher degree of severity, and their progression will occur earlier on, where they may end up requiring a cochlear implant, like in this picture here. The unusual thing is that the hearing loss can also fluctuate. So they may come in and have better hearing one day, and 3 months later have worse hearing, and then a follow-up audio, it looks better again. And it's a little difficult to understand why that occurs. Again, this is thought to be more like an immune issue like autoimmune inner ear disease, and potentially that's what's causing the fluctuation. It is not explainable by middle ear fluid or other middle ear problems. It is sensory neural, so it's in the inner ear piece. And this can occur in one or both ears. And it can also occur asymmetrically. So children who are born with symptomatic CMV were more likely to have bilateral hearing loss, whereas asymptomatic children may just have unilateral, or there may be a difference in the severity between one ear and the other. And this chart essentially shows a comparison of these different findings by study. So there were quite a few studies that looked at the types of hearing loss, and the studies ranged from the early 90s up to 2014, and they ranged in number from 28 patients to over 800 patients. And you can see that a majority of them had severe hearing loss in that column right here. There's a reasonable number that have asymmetric hearing loss, and that it also is progressive, anywhere from 20% to 60%. And this is similar for fluctuation. So anywhere from 11% to 40% will have fluctuation. The point of this is that it is critical for these children to have frequent audiologic follow-ups and monitoring, and if they are getting or using amplification, that those devices be adjusted as needed, especially for children who have either progressive or fluctuating hearing loss. This chart shows the age at detection of sensory neural hearing loss in these children, and kind of explains why they went up to age 4 in the CHIMES study. But you can see if you define hearing loss as a greater than 20 decibel loss, at age 1 month, about 5% will have sensory neural hearing loss, and by the age of 6, up to 15% will have sensory neural hearing loss. And then this study looked at children who had CMV screening versus not. So children who had CMV screening had a higher likelihood of getting a follow-up audiogram within 3 months of diagnosis compared to children who did not have CMV screening. So the hashed lines are the diagnostic hearing evaluation, and the solid black bars are no diagnostic evaluation. So you can see on the left-hand side, those children did not have CMV screening, and on the right side, they did. And so you can see a big improvement in those that got follow-up audiograms. This just describes what kind of tests can be done based on age. So at all ages, children can have otoacoustic emission testing, and that measures the cochlear response to a stimulus. So a sound is presented to the ear, and then the inner ear cochlea will respond, and the computer can measure that. So if there's hearing loss, it will be identified if it's related to the cochlea or to the middle ear. If it is the hearing nerve or the eighth nerve, it might be missed. You can have present OAEs even with an abnormal eighth nerve. From birth to 9 months, auditory brainstem response testing or automated auditory brainstem response testing can be done, and that will test the cochlea all the way up to the cortex. So it is testing cranial nerve 8 function as well. From 6 months to 2.5 years, they can do visual reinforcement audiometry, and that's sort of a behavioral response, and usually will test the best hearing ear. And then from 2.5 to about 4.5, they can do play audiometry, which also is a behavioral response and will test the best hearing ear. And then by the time they hit 5, they're able to do routine audiometry, where you can test each individual ear, and they do the clicker or raise their hand. ABRs can be done at any time under sedation. So for children from birth to about 6 months of age, they may be done just under natural sleep, but they can definitely be done at any point in time under sedation to determine the hearing level in each individual ear, both sensory neural and conductive hearing loss. So the Joint Committee on Infant Hearing has an initiative that's called the 136 Initiative. And what their recommendations are is that screening should be repeated within 1 month of a failed newborn hearing screen. and then diagnostic testing done within 3 months, ideally within 2 months. If they continue to have indication of hearing loss, there should be intervention offered within 3 to 6 months, and that may be hearing amplification, referral for cochlear implant evaluation, and referral to early intervention. And if it's confirmed to be congenital CMV, then it's important for families to understand that they do need to have regular and consistent audiological follow-up because of the risk of progressive hearing loss or the risk of fluctuating hearing loss over time. They need to understand that they will likely need amplification and that they may progress on to needing cochlear implantation, and that they would be referred to speech therapy when appropriate as well. So, since these children are at risk for delayed onset or progressive hearing loss, they should be monitored regularly. And the recommendations would be monitoring hearing every 6 months until about the age of 3, annually at least until the age of 6, and more frequent monitoring if needed if the hearing is fluctuating. Some people would argue they should be monitored longer till age 10 or 12 because of the risk of delayed onset hearing loss even into teenage years. So some of these advocacy initiatives that we are working on is in conjunction with the National CMV Foundation and their legislative goals. So this QR code is the code to the National CMV Foundation website. They have a lot of information for providers as well as patients and parents. And their goals are to advocate women of childbearing age, as well as the general public, healthcare providers, and health departments about the risks and prevention of congenital CMV. They also have a goal to implement a national program to screen every newborn for congenital CMV, to increase funding for research, and to advocate for vaccine development. So back to this graphic from this year of congenital CMV legislation in the United States. North Carolina and South Carolina, neither state has any sort of existing legislation. However, a lot of the major hospitals and health centers do test for CMV when babies fail their newborn hearing screen, regardless of not having a statewide mandate. In our institution, we are actually starting universal screening for the NICU babies, whether or not they have any symptoms or any other at-risk reasons for developing CMV. So we'll be doing some studies to look at the outcomes of those babies. And we do have some bills that are models from some of these other states that can help us crafting legislation for the state. And these are some of the different bills across the country regarding CMV. A lot advocate for just CMV education. Some advocate for CMV hearing targeted testing. Some advocate for universal testing. This year, the American Academy of Otolaryngology Head and Neck Surgery put a position statement out regarding CMV and advocated for universal newborn CMV screening in order to identify these children early and allow for them to be monitored. And then also advocated for information regarding prevention of CMV, including hand hygiene and personal protective equipment, especially so that since these children may or may not show any sort of symptoms. And this QR code is the link to the position statements from the Academy. And even nationally, there is a bill in Congress, H.R. 7542, that's called the Stop CMV Act of 2024. And it's talking about screening for CMV as well as education. It has not been passed yet, but we are hopeful. But there are some controversies regarding screening options and the best methods and what to do with positive results. So one of the biggest debates is whether you do hearing targeted versus universal screening for CMV. And that's because sensorineural hearing loss is such an important consequence of CCMV. If you do universal newborn hearing screening, which is done currently, it's only going to detect about half of the sensory neural hearing loss that is caused by CMV. So that means we're missing a lot of children that will develop sensory neural hearing loss as a result of CMV only by screening their hearing. So the goal was to create a different approach to identify these children as early as possible. Again, we talked about the timing for testing and that it has to be done within 3 weeks because of the risk of getting acquired CMV, which does not have any sequelae, and the importance of early identification, which leads then to early intervention. Quite a few states have done targeted hearing screening legislation. So that means these children who are born without any other symptoms other than failing their newborn hearing screen will get CMV tested by either salivary or in PCR, and if they're positive, then confirmatory cultures. Currently, Minnesota has a bill for universal CMV screening, and Connecticut is supposed to start universal screening in 2025. New York is considering introducing legislation on universal screening, and they're doing a study on that. And there are several other states that have more proposed legislation. Canada is also undergoing an evaluation of a universal screening protocol that they've had in place for several years in determining the results and outcomes. And the key for that is that to remember that 15% of children who are born with CCMV that pass their newborn hearing screens still can develop delayed onset hearing loss. One of these studies looked at, if you look at newborn hearing screening only, how do we determine which children are going to be missed? So they looked at 388 neonates that had CCMV identified, and then looked at their audiologic exams at birth because they identified CCMV. And those had about 5% hearing loss, which is similar to what we've seen in these other studies. And then by age 6, they had 15% that came up with hearing loss. And in those, 36% of them were symptomatic at birth and 11% were asymptomatic. So this kind of confirms some of the other studies that we talked about earlier on today. This chart kind of breaks down the difference between looking at CMV screening for hearing targeted, where you're only testing those children who fail the newborn hearing screen. And the next chart is going to show the difference with the universal hearing screen. So if you have 4 million births a year, 20,000 of those are positive for CCMV. 2,000 of those are symptomatic. And of those that are symptomatic, about half or slightly more than half will pass their newborn hearing screen, and about 560 failed their newborn hearing screen. So you can sort of see that those were captured because they were symptomatic. But then if you look at the right-hand side of this chart, 18,000 of these children are asymptomatic. And of those 18,000 children, if 17,000 pass their newborn hearing screen, they could potentially be missed for late onset hearing loss. And say 1,000 of those failed their newborn hearing screen, and then about half of those ended up passing subsequent hearing tests. So you've captured a small percent of children who potentially who have hearing loss, but you're missing a group that will develop hearing loss later. And here, if you look at it for universal screening, same number, 4 million births a year, same number who are positive for CCMV. You have the same side of the 2,000 symptomatic and those with hearing loss at birth versus normal hearing at birth. But then if you look at the side where there's 18,000 asymptomatic, about 900 of those have isolated hearing loss, and then 17,000 had normal hearing at birth, but now you know that they need to be monitored. So these children now are identified, and of those, up to 15% could develop late onset hearing loss. So now we're able to recommend audiologic follow-up and counseling. So the controversy about what to do with asymptomatic CMV is pretty real because of the risks of therapy. Those antivirals do have risks of adverse events. And there's also increased healthcare costs and parental worry. So And then again, uncertainty if treatment actually prevents delayed onset or progressive hearing loss. There are some studies that show it probably does help decrease the progression and potentially may prevent some of the delayed onset, but those are still to be validated. But if you speak to parents, they would like to know if their child has a risk of hearing loss, and then they can plan for frequent audiologic follow-up and developmental assessments, be prepared for any kind of issues in school. And so it makes a big difference to them whether or not their child could potentially have issues related to CCMV. The other issue is the lack of vaccines. So currently, there is no approved CMV vaccine. There are a few that are in phase 1 and 2 trials, and then there's one in a phase 3 trial. The goals of the vaccine are to target both the capsid, which houses the nucleotide, as well as the glycoprotein, which is around the outer coat, and also to stimulate T cells to decrease the likelihood of reactivation. Like we said, a significant percent of mothers who've had CMV can still have reactivation or have a different strain. And also, induction of IgA may help decrease mucosal entry of the virus, which is how the virus gets into the body in the first place. So there are several places where vaccines can make a difference. It's challenging just to create the vaccines to do this. There have been some promising studies in both those phase 1 and phase 2 trials, though. In 2019, the American Academy of Pediatrics passed a resolution that supports counseling and education on CMV. And as we said early on, almost 90% of expectant mothers have never heard of this virus, so they don't know that their baby is at risk. It is not a regular curriculum in OBGYN training programs. Some training programs are now starting to include this information, and there's some goals to try to put some information in OBGYN offices regarding prevention and information for expectant mothers. Also providing pediatricians and family practitioners information on where to refer for audiologic follow-up so that these children have regular follow-up, and educating the public on prevention, hand washing, not sharing pacifiers, not sharing utensils. Sort of similar to COVID-19 without the masking. And here you can see from the National CMV Foundation, they have this nice little graphic that shows ways to prevent transmission of congenital CMV, avoiding contact with saliva with the babies, not using their pacifiers or try to clean their pacifiers by cleaning in your mouth, not sharing utensils or straws, having separate toothbrushes, and frequent hand washing. So for North Carolina, the things that are next is a review of existing legislation and pending legislation to determine what works best for our state. Ideally, looking at either expanded targeted screening, meaning children who either fail their newborn hearing screen or are preterm or have other risk factors that could make them a higher likelihood of having congenital CMV, versus doing universal screening, and then an education component for either of these. Ideally, adding this to the required universal screening protocol would be the best way to go, but that is a huge process, and so that may take quite a few years to implement. And then funding for testing and follow-up care. So funding is one of the bigger issues. As you saw, the risk of having CCMV increases healthcare costs significantly across the lifetime for those children. So if we can identify them early and intervene early, we may make an impact on the total healthcare costs as well. So the key messages here are that congenital CMV is an important public health issue. It is the most common cause of congenital infections and a major cause of hearing loss and disability in children. It is really important for parents and providers to know more about it and to be aware of it. Most children who have CCMV have no symptoms at birth, and so they cannot be identified without testing. And about half of the hearing loss that's due to CCMV occurs after birth, and so it's a delayed onset, and it can be missed by just doing universal newborn hearing screen. There are rapid and reliable testing methods, such as salivary or urine PCR analysis, to identify CMV infections. And so these are needed for early identification. Then we would do confirmatory cultures to determine if the child actually has the infection. Once you know, then you'd be able to determine how frequently they should be followed up and try to stay on top of their hearing, and that decreases the likelihood of language delays and learning delays. And then educating the public on the risks of CCMV can help change the course of this disease. So audiologists are an important part of the team to help identify these children and provide early intervention and improved outcomes. So if you have any questions, I would be happy to address those. And thank you so much for your attention. And I hope to get you involved in our legislative advocacy. Thank you.
Thank you, Dr. Raynor, for your informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen. We'll answer as many of your questions as we have time for. Let's go ahead and get started here. Our first question asks, what are some of the more important risk factors to consider in an expanded targeted screening protocol?
Thank you for that. So the targeted screening itself was for otherwise asymptomatic babies who fail their newborn hearing screen. Now they would be considered symptomatic. In an expanded targeted screening protocol, we would take into consideration prematurity, number of younger children in the household, ideally children who are in daycare or under the age of 5, because those increase the likelihood of the maternal CMV infection during that particular pregnancy. And then any other potential things, such as what kind of housing situation they live in, which may be a little more tricky to answer. But certainly children who are premature, or if there are multiple younger children in the household, those would be good reasons to do the expanded targeted screening protocol.
Excellent, thank you. All right, our next question that we have here asks, what is the environmental source of CMV?
So it is a very common ubiquitous virus. 90% of adults over age 40 have it or carry it, so they can excrete it in their saliva or their mucus from their nose. And so that's where it sort of spreads. It is a class of herpes virus. The original source, I'm not sure where it came from, but it is very global. And if you test most adults for CMV antibodies, you will find they have positive antibodies in their system.
Great, thank you. All right, moving on to our next question here. It asks, who were the key players in getting the Duke screening protocol approved, and was it difficult to get approved without formal legislation in place?
So in terms of the original screening protocol, which was essentially a hearing targeted protocol, it was a combination of pediatric infectious disease, neonatology, pediatrics, audiology, and otolaryngology. So what would happen is the babies would fail their newborn hearing screen, they would go home, they would come back to the audiologist to get a follow-up test, and if they failed that, it would trigger getting the urine or saliva swab done for PCR. The problem was we didn't always get them back within 3 weeks. So we met as a group, this was back in 2018 or 2019, and talked about at least testing those babies that fail their newborn hearing screen while still in the hospital, because it's difficult to get them back into the office in a timely manner. The newer screening protocol that's being done is universal screening in the neonatal ICU. And we are working together with pediatric infectious disease and neonatology on these babies. So we're testing all the babies that started in January of this year. And we'll be looking at outcomes, and we'll be looking at whether there's an impact in their birth weight and also how premature they were to see if we have a higher incidence of congenital CMV in the more premature babies, less than 35 weeks versus 35 to 37 weeks.
Great, thank you. And maybe more of a piggyback question. Our next question asks, in Duke's screening protocol, do they start with a saliva sample or do they go directly to urine?
So typically they start with a saliva sample, and then if it's positive, then they will do a confirmatory urine culture. One option that could be really cost effective that we're thinking about implementing in the NICU if we're doing universal screening is doing batched testing. So you actually do multiple babies' saliva samples. If that whole batch is negative, then that group is negative. If anybody in that batch is positive, then you would isolate the patient that's positive and then do the confirmatory urine culture. The advantage of that is that the cost of the testing is significantly lower. So we'll be looking at that. Some of the problems with the saliva is that you can have false positives, especially because CMV can be excreted in breast milk. And so if the mom is breastfeeding or if they're doing pump breast milk, and they test within 20 minutes of feeding, there's a possibility that they're testing the mom's breast milk supply and not the baby's actual saliva. So they are very careful to try to do the testing 30 minutes after feeding or longer, making sure they wipe the baby's mouth out very well. But there are times where this potentially still could happen. And so this is where the confirmatory urine will tell for sure if they have CMV or not.
Great, thank you. All right, we have time for a couple more questions, so I'm going to ask our next one here. This one is a two-part, so it says, can you outline the steps taken to implement universal screening for the high-risk population, and were extensive education, publications, or other tools used, and which was most effective?
So the steps that were taken were essentially having conversations between pediatric infectious disease, neonatology, audiology, and us. One of the issues with preterm babies is they may or may not get their newborn hearing screening done early on, especially if they have a lot of underlying medical problems. So that can be a barrier in terms of getting the CMV testing. By doing the CMV testing, regardless of whether or not they had a hearing test done, at least we'll have the answer as to whether or not they are CMV positive. And then they would get their hearing test done as soon as they're medically stable enough to do so. So it sort of involves multiple stakeholders in terms of getting this done. Certainly in kids who are not high risk, who are just normal full-term nursery, this will be significantly easier to do. But the ones that have multiple medical problems may be a little bit more challenging. But doing the saliva swab, fortunately, is not invasive, really. They just essentially swab the mouth and then send it. So it doesn't necessarily cause any problems with babies who may otherwise have some difficulties undergoing any other procedures. As far as education, it's really a matter of having the nursing staff in the ICN or the NICU being aware of what's going on, knowing about the timing of when to collect the sample. There were not any specific educational tools used for this, but I think as we do this study and see where we are and see how many babies may end up getting missed because of the universal screening protocol, this will give us an idea of what sort of educational program we should put together, and especially if we are able to expand this out to all the babies. So hopefully that answered both parts of that.
Yes, I think it definitely did. All right, our last question that we have time for today says, in your opinion, what are the critical factors missing in advocating for legislative adoption of expanded, targeted, or universal screenings?
So one of the biggest things is the cost analysis, especially when it comes to any sort of legislation. That's one of the first questions legislators will ask is, how much is this going to cost? And where's the money coming from? How are we paying for it? Fortunately, the salivary testing is not ridiculously expensive. And if batch testing turns out to be a reasonable, cost-effective way to do that, it may help sway legislators that it would be reasonable to do this and identify these children early. The biggest thing is also looking at the downstream long-term effects of children who are missed and have struggles in school, language delays, things like that, because they were not identified in advance and they did not get routine follow-up audiometry and intervention. So it's sort of a matter of looking at those numbers and really understanding that whether it may cost a little bit more at the front end, it can certainly save a lot of money at the back end in these children's productivity and things like that. But I would say that's probably the biggest thing that legislators are going to be asking about.
Great. Thank you again, Dr. Raynor, for your time today and your important research. We would also like to thank LabRoots and our sponsor, DiaSorin, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today and those submitted during the on-demand period will be addressed by our speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care, everyone. Goodbye.
Thank you so much.